Okay, good morning. Today we're going to deal with the reproductive system. This will be dealt with in two lectures. Today's lecture is about the male reproductive system, and then on Friday we will deal with the female reproductive system. So regarding the reproductive systems in general, they will allow sexual reproduction, and this produces new individuals. There are germ cells called gametes, which are either the sperm or the secondary oocyte, and each one of them, they have what we call the haploid number of chromosomes. That's to say, half of the number of chromosomes that are present in other cells in the body, the somatic cells in the body. So when these two gametes, they will meet during fertilization, then they will regain the complete set of chromosomes during fertilization. We will have, again, the diploid number of chromosomes, 23 pairs of chromosomes. The reproductive systems, whether male or female, they consist of primary sex organs, which we call them gonads. So in the male, the gonad is the testis, and its counterpart in the female, it's the ovary. And these gonads, they produce the germ cells as well as the hormones. So they have more than one function. And there are accessory sex organs like ducts, other glands, and supporting structures, as we will see in the male. For example, the ducts are the seminiferous tubules, the epididymis, the vas or ductus deferens. Other glands like the seminal vesicles, Cowper's glands, supporting structures like the prostate, the penis, and so on. So this is the general introduction about the reproductive systems. It's somewhere else, isn't it? Yeah. Okay. Okay. So what are the general functions of the male reproductive system? The testis, as I mentioned, the testis, it produces the sperms as well as the hormone, testosterone. So it's a gonad, produces the gametes and produces the sex hormones. And there are the ducts, which help transfer or transport the sperms. They can also store the sperms, so they are stored in the epididymis here. This is one of the ducts, and then the vas or ductus deferens, which reaches backwards and enters the abdomen and reaches behind the bladder until it opens into the prostate gland. And then we have the accessory sex glands, which produce most of the fluid of the semen. So the sperms are produced by the testis, but the fluid of the semen, most of it, actually 70% of it, is produced in the seminal vesicles, 25% is produced by the prostate, and then here we have the bulbourethral glands, which also contribute to that seminal fluid. The penis here contains, we will discuss the structure of the penis, but as you can see here, it contains the urethra, and the urethra, therefore, is a common passageway in the male. It's a common passageway for the sperms and for the urine, because it will receive the sperms as it passes through the prostate. Remember last time we mentioned that the urethra passes through the prostate gland. It has three parts: prostatic urethra, membranous urethra, and the penile urethra. So as it passes through the prostate, it receives the ejaculatory ducts. So it's a common passageway for both urine and semen. The testis is located in the scrotum, and in other words, it's located outside the body, and there is a reason for that, and that the optimum temperature in which the testis functions should be about 2 to 3 degrees centigrade, less than the temperature of the body. So that's why the testis is located outside the body. And if the testis is not outside the body for one reason or another, as we are going to mention in a moment, then they have to be taken down into the scrotum. The skin of the scrotum, which is very thin, contains smooth muscle fibers that control the area of the scrotum. And these smooth muscle fibers, they have a special name. They are called dartus muscle. Please don't confuse this name with the smooth muscle fibers that form, that are present in the wall of the urinary bladder. These are called detrusor muscle fibers. This is dartus muscle fibers. They are present in the wall of the scrotum. And as I said, that the temperature here is controlled by several mechanisms. One of these mechanisms is that the dartus muscle, which is present in the wall of the scrotum, when it contracts, it will reduce the surface area and push of the scrotum and push the testis up. So this happens, for example, during arousal or in cold weather. But in hot weather, then the testis should be pushed or down outside the body, away from the central body temperature, in order to reduce its temperature. So dartus muscle plays a role in controlling the temperature of the testis, as well as another muscle, which is a skeletal muscle here. It's called cremaster muscle. This muscle is present in the sheath that surrounds the spermatic cord. So this is the spermatic cord. It's a bundle of vessels, nerves, and the ducts, which is the vas. So all of them are surrounded by multiple fibrous sheaths, and together they will constitute what we call the spermatic cord. And within the sheath, within the fascia, there are these muscle fibers, skeletal muscle fibers, which are called cremaster muscle. And when cremaster muscle contracts, therefore, it will elevate the testis and make the testis close to the body temperature. And again, this happens in cold weather. In hot weather, the testis descends down. There is another mechanism, which is I didn't mention here on the slide, but it's worthy to notice that there is another mechanism here, which is the blood vessels. Look at the veins that surround the artery, the testicular artery. They act like a radiator around the artery, so they will reduce the temperature of blood coming to the artery. So all these mechanisms work together to maintain optimal temperature for the testis to work. The testis, and it's actually both gonads, the testis and the ovary, they develop high up in the lumbar region, in the posterior abdominal wall, and then that's during embryonic life, and then they descend. So the journey of the ovary will stop at the pelvis, while the testis will continue down. So the testis continues down through the anterior abdominal wall until it reaches the scrotum, and this happens in during the 7th month of fetal development. So it passes through the anterior abdominal wall. If it fails to reach the scrotum, this is called undescended testis, and it should be brought down. Some male infants, especially if they are premature, there's a premature birth, they will have undescended testis, and so they will wait until about 18 months of age. After that, it should be brought down, because the testis will not function if it is undescended. It's not, and in addition to that, it is more prone to trauma, it's more prone to cancer. So there are many reasons why they should bring the testis surgically down. As the testis is descending, it passes through the anterior abdominal wall. So there is a passageway here, an oblique passageway through the muscles that form the anterior abdominal wall until it reaches the scrotum. This means that there is a weakness in the anterior abdominal wall. This will create a weakness, and this weakness will predispose for what we call a hernia where a part of the small intestine, for example, or even part of the peritoneum might push itself through this weakness and reach the scrotum. This is called inguinal hernia, and it's more common in the males because the inguinal canal will be weaker in the males than in the females, because they facilitate the descent of the testis, but the ovary does not pass through it. The descent of the ovary stops at the pelvis. It doesn't go downward. The testes are oval structures, paired oval structures. They are surrounded by very thick connective tissue called tunica albuginea. Alba means white, So they are very thick, and when you dissect them, you will find that it's really thick and white. So that's why it's called tunica albuginea. And there are multiple fibrous tissue septa that divide the testis into compartments or lobules. And in each of these lobules, you can see that there are tubules, very small, tiny, hair-like tubules, and convoluted, so they are called seminiferous tubules. These are the tubules that are present in the testis. And it is in these tubules that the sperms are formed. So when you have a section in the testis, histological section, you will find multiple profiles of seminiferous tubules because they are convoluted. So in section, you will find multiple profiles of these tubules. So this is one of the seminiferous tubules. And here, in the wall of the seminiferous tubules, the sperms are forming. So you can find all the stages of sperm development. So the primary stages are located at the periphery until the sperm is formed here and will be released into the lumen. Okay? And so you have like spermatogonia, primary spermatocyte, secondary spermatocyte, and then we have the spermatid, and then the spermatid will form the sperm. And in between these cells, in between these spermatogenic cells, the cells that are going to develop and form the sperm, in between them, there are other cells which are supporting cells. Okay? So they are called supporting cells, sustentacular cells, or Sertoli cells. In addition to that, I'm going to come back to Sertoli cells, but before that, there are other cells which are present here in the interstitial spaces, in the spaces between the seminiferous tubules, outside the seminiferous tubules. And these are called Leydig cells or interstitial cells, and these are the cells that produce the testosterone. The testosterone does not need to go into these tubules. These tubules are for the sperm. Testosterone is a hormone, so it goes to the blood. So it doesn't need to be present inside the seminiferous tubule because it will be secreted into the blood. And it is secreted by another group of cells, which is called the interstitial cells of Leydig. This is a diagram probably to show you again the cells of the spermatogenic series. Here you can see this is the spermatogonium. These cells, they to start with, they are like somatic cells. They have the 2N, they are diploid number of chromosomes, 46 chromosomes, 23 pairs of chromosomes. And as they develop, they will form the spermatid and the sperm, which has 1N, only a haploid number of chromosomes. Here you can see that the whole process of development is called spermatogenesis, and the spermatid here is formed, and then it develops into a sperm cell or spermatozoon. This process is just a process of change of shape. There is no cell division. The cell doesn't divide, but it just changes its shape into a mature sperm. So this process is called spermiogenesis. It is the final stage of spermatogenesis, is this, we call it the spermiogenesis. The entire process takes about 70 days. And here in the interstitial tissue, you will find the Leydig cells, the interstitial cells. And you can see the close proximity of these cells to blood vessels because they produce the hormone to the blood vessel. They produce the testosterone. The supporting cells, you will find them here. So they are very big cells, as you can see. And these are the sustentacular cells or Sertoli cells. They support the cells of the spermatogenic series during their development. They act like a barrier. We call it a blood-testis barrier. So they separate these developing cells from the antigens that are, from the antibodies that are present in the blood. Because as these cells develop from 2N to 1N number of chromosomes, they will be recognized by the body as foreign cells. So they are protected. Otherwise, if there's no such barrier protecting them from blood, then they will be attacked by antibodies. Okay? So these cells, the supporting cells, they have a very important function in acting like a barrier. And at the same time, they act as a barrier between the developing cells and the blood, but at the same time they will provide nourishment. So they will act like a proxy between the blood and these cells. They provide nourishment and support for the cells, for the cells of the spermatogenic series, and also they will produce some fluid into the lumen of the seminiferous tubule and secrete a hormone called inhibin, which acts to inhibit the follicular stimulating hormone coming from the anterior pituitary gland. The anterior pituitary controls the function of the testis. We mentioned that before, by follicular stimulating hormone and luteinizing hormone. So the follicular stimulating hormone, it stimulates the production of sperms, while the luteinizing hormone acts on these cells and produce the testosterone. This is the mature sperm here after the process of spermiogenesis, and you can see it has a head which is modified. It contains the nucleus. This nucleus contains 23 chromosomes only, n number of chromosomes, and there is a piece here which is called acrosome. We probably mentioned that probably in the first or second lecture during this course. This is a modified lysosome. The lysosomes, which contain proteolytic enzymes, digestive enzymes. So this is a big lysosome that contains these enzymes that will help the sperm to penetrate the oocyte during fertilization. It's just present at the tip, so that after fertilization, the nucleus of the sperm will be injected into the oocyte. And then we have a middle piece here, which is contains a lot of mitochondria, and this can be understood because a lot of energy is required for the movement of the sperm, the movement of the flagellum here. The flagellum it beats. It's remember we mentioned the difference between flagellum and the cilia. The cilia usually are multiple, and they cause movement of like mucus covering them, like in case of the respiratory tract, but the flagellum is usually a single one, and it causes the movement of the cell itself. So this is a flagellum, and it requires energy. So this energy is provided by the multiple mitochondria that are present in the middle piece of the sperm. This is how the spermatogenesis is controlled. I mentioned that earlier. The LH and FSH. LH stimulates the Leydig cells to produce the testosterone, and the FSH stimulates spermatogenesis. And the testosterone controls the male secondary sexual characteristics, sexual behavior, male type of metabolism, and deepening of the voice. Now, returning back to anatomy, we have the ducts. So the ducts start as the seminiferous tubules. We mentioned about them, and these seminiferous tubules will join together and form a single tube here, which is called the ductus epididymis. So this is a tube which it's a very long tube, narrow at its beginning, and then it starts to become wider and thicker, and this is called the epididymis. It is surrounded by connective tissue, and from the epididymis arises a single duct, one duct that has a very, very thick wall, and this is called the vas or the ductus deferens, that goes up and goes into the abdomen to open into the prostate, the ductus deferens or the vas deferens. This is this is the tube of the epididymis. The epididymis is located here, and this is the tube. It is lined by pseudostratified columnar ciliated epithelium, and in the lumen you can see a lot of spermatocytes. Spermatocytes are present here because they mature and they are stored. So the epididymis, which is a very, very long tube, convoluted, is the site for the maturation and storage of the sperms. And then during ejaculation, this tube will propel the stored sperms through the vase, and the vase will propel the sperms to go up into the prostate. This is the vase. It enters, see, this is it's a very thick wall. It has a very thick wall, muscular wall, and these muscles are needed to propel the sperms rapidly at the time of ejaculation through a distance of about like 18 inches. It's about 18 inches in length from the testis back to the back of the urinary bladder. Here it joins the duct of the seminal vesicle. This is the seminal vesicle that produces about 70% of the fluid of the fluid of the semen, and they join together. They form the ejaculatory duct. One ejaculatory duct here, the other one on the other side. They open into the prostatic urethra. And this is a cross section of the vase. You can see how thick the muscles are there. So, like, it can be easily palpated among the contents of the spermatic cord. Remember here, we said that the spermatic cord here, that's the spermatic cord. It contains blood vessels, nerves, and the vase. But the vase can be easily palpated because it's a very, very thick wall, thick muscular wall. And again, I repeat, these muscles are required to propel the sperms rapidly from their, where they are stored in the epididymis, close to the testis, toward the prostate. It's again lined by pseudostratified columnar epithelium and covered by heavy coating of muscle, as I mentioned. And this is the vase, which is commonly or usually this is the part that is cut and ligated for male sterilization. It can be done here through the scrotum, upper part of the scrotum. It is ligated on both sides, and then it is cut. Cutting of the vase does not mean that it will stop or will affect the secondary sexual characteristics of a man, because these depend on testosterone. Testosterone is secreted into the blood. It doesn't go through the vase. So it will not be affected. It will not stop ejaculation because the semen actually is about 95%, or let's say more than 95% of the semen. The fluid is produced by glands that are located away from the testis. So it's only the ejaculate will not contain sperms. That's it. Okay? So the blood vessels are not cut, and it has no effect on sexual desire or ejaculation. Vasectomy. Now let's deal with the accessory sex glands. We have, one of them is the seminal vesicles. These are elongated sac-like structures. One of them here, the other one there. Seminal vesicles. These, they produce a fluid which is added to the sperms during ejaculation. So the sperms will come from the vase, and as they unite with a duct of the seminal vesicle, this fluid will be poured here. About 70% of the volume, or 60% of the volume of semen, 60%, is produced by the seminal vesicles. Be careful, seminal vesicles do not store the sperms. The sperms are stored in the epididymis. These seminal vesicles, they produce the fluid that is added, most of the fluid that is added to the sperm, and this fluid is actually needed because, first of all, the fluid is alkaline, and it neutralizes the acidity of the vagina and the distal part of the urethra. The acidity of the vagina and distal part of the urethra, in fact, is required for protection against infection. So they neutralize the acidity, so that's why it is alkaline, and it provides fructose. This is a very good source for ATP, energy that is required for the movement of the flagellum of the sperm, and so they provide nourishment for the sperm during their journey. And also they contain prostaglandins, which stimulate the motility and viability of the sperm, and they contain a clotting protein which causes coagulation of the semen. Semen coagulates like 5 minutes after ejaculation. It coagulates The reason is not so clear, but because after like 10 or 15 minutes after that, it liquefies again. So it's not very clear why it coagulates, and the coagulation is produced by clotting factors that are present in the fluid, in the seminal fluid of the seminal vesicle. So it provides, it is again, I repeat, this fluid is important because it provides nourishment for the sperm. It is alkaline, and it induces the motility of the sperm by the prostaglandins it contains and the clotting. The other gland here is the prostate gland. The prostate gland, as you can see, it is located just below the neck of the bladder. This is the urinary bladder. Below the neck of the urinary bladder, it is the size and shape of a chestnut, the prostate. And you can see here that the urethra passes into the prostate, and this part is called the prostatic urethra, and it receives the ejaculatory ducts. But this is not only the only function of the prostate. Actually, the prostate has a more important function in that it is a gland. It produces fluid, prostatic fluid, and this fluid is the milky fluid, and it's about 25% of the volume of the ejaculate. So 60% is from the seminal vesicles, 25% is from the prostate. And the fluid contains citric acid. Again, this is for the nourishment for the sperm, another source of nourishment for the sperm. And it contains an enzyme, which is called the prostate-specific antigen. And this is the one that is responsible for the liquefaction of the sperm after it coagulates. As I mentioned, it coagulates and then liquefies. So the fluid here is again for nourishment and liquefaction of the ejaculate. The prostate-specific antigen actually is usually it is measured in men above 40 years of age. There's they are scanned annually for that, because a rapid increase in prostate-specific antigen might indicate prostate cancer. So it's one of the biochemical examinations that are usually done annually for men. It's an indicator, not the level of the enzyme itself, but the amount of increase in the enzyme can give an idea whether there's cancer or not. Here you can see the location of the prostate. So the prostate is below the urinary bladder. It's in front of the rectum. That's why the prostate is usually examined by a perectal examination, to feel the size of the prostate, to feel the consistency of the prostate. When there is tumor of the prostate will become hard to feel and might increase in size. Another enlargement of the prostate that commonly takes place in men above 45 years of age, this is called benign prostatic hyperplasia, where there is increase in the size of the prostate. It is not a tumor, but the problem here is that when the prostate increases in size, it will press on the urethra. So this will create problems with urination because it presses on the urethra, which passes through the prostate. The other glands here, we have the bulbourethral glands. These are very small glands, like pea size, and they are located in the floor of the pelvis, in the what we call the urogenital diaphragm, where the sphincter of the urethra is located, the sphincter muscle is located, and they open, their ducts open into the urethra, not the prostatic urethra, but the penile urethra. These are, they contribute to a very small amount of the ejaculate, but usually they are secreted, or what they secrete appears before ejaculation, and it helps in lubrication during intercourse. So the semen is a mixture of sperm and seminal fluid, as I mentioned. If you do vasectomy, then there is no sperm, it's only seminal fluid. And the seminal fluid is produced by partly by seminiferous tubules, mainly by seminal vesicles, and then the prostate, and then minimally by bulbourethral glands. The size, the ejaculate is 2.5 to 5 ml in volume. It contains about 50 to 150 million per ml, the number of sperms. If it is less than 20, then this is a problem. And it coagulates, as I said, within 15 minutes, then reliquefies because of the prostate-specific antigen after 15 minutes. During semen analysis, the sperms, it's not only the number of sperms that is important, but it is the activity and the motility of the sperm. So if there's low count, less than 20, that's a problem. If they have an abnormal shape, not the shapes that we have seen now, that's a problem. And if they are some of the sperms and people with infertility, they are either immotile or they have abnormal motility. They just rotate around themselves. They don't go forwards. Now, the urethra, this is the passageway, the common passageway for the semen and for the urine. And it has three parts. Here's the prostate. In the prostate, it is the widest part of the urethra. It's called the prostatic urethra. And then it passes through the urogenital diaphragm here at the floor of the pelvis. And it's called the membranous urethra. And then it passes through the penis. It's called the penile urethra, or they call it the spongy urethra, because it passes in part of the penis, which is called the corpus spongiosum, the spongy body of the penis. So that's why it's also called the spongy urethra. The penile urethra is sometimes referred to as the spongy urethra. The penis is composed of body of the penis and roots. So these three structures, 1, 2, 3, they constitute the root of the penis. And then we have the root of the penis, and then we have the the body of the penis, and then we have the glands of the penis. And the body is composed of three tissue masses, which are called erectile tissue. And erectile tissue, which is present in other places in the body, but not as in the penis or in the counterpart of the penis, which is the clitoris in the female, this erectile tissue is actually a spongy tissue. Look at it here or here. This is a diagram. This is an actual penis that is cut in a section. And you can see that this fibrous tissue, it looks like a sponge. And there are spaces here. These spaces are called cavernous spaces, and they are usually filled with blood. Okay, so when the blood gushes into these spaces, there will be more blood in them, and so they will elongate and become tighter. And this is what happens during erection of any erectile tissue, the penis or other erectile tissue in the body. So these three pairs of erectile tissue, we have corpus. Corpus means body. So we have corpus cavernosum here and another corpus cavernosum. And here's the corpus spongiosum. So 1, 2, 3, the corpus spongiosum is present downwards here. Look at, there is an artery here in these corpora, and it is these arteries that will spill the blood into the cavernous spaces and makes the tissue erected. So corpus cavernosus, and corpus spongiosum. And within the corpus spongiosum, you can find the urethra. The urethra is present in the corpus spongiosum. That's why it's called the spongy urethra. Now, this is the body of the penis. It starts as the root. So here is the root of the penis. The root is made of three structures again. So we have the crus. So the corpus cavernosum continues backwards as the crus, which, as you can see here, it's attached to the hip bone. Okay? And it's covered by fibrous tissue and by muscle fibers. And then the corpus spongiosum continues backwards as the bulb. So you have a single bulb, here, but 2 crura, because you have two corpus spongiosum, two corpora cavernosa. So 2 crura posteriorly, they continue as 2 crura, but there is 1 corpus spongiosum. Corpus spongiosum, posteriorly it distends as the bulb, and anteriorly the same corpus spongiosum distends as the glans of the penis. This piece of skin here is called the prepuce, or the foreskin, and it is the part that is removed in people who are circumcised. So we have 2 crura and a bulb. Each of them, as you can see here, this is the root of the penis. Each one of them is covered by muscles. So, well, you have to know the names of these muscles. One of them is called ischiocavernosus, and the other is called bulbospongiosus. And these muscles, as they contract, they will help in erection. Not only they help in erection, but bulbospongiosus actually, because it's present in the bulb of the penis, which continues as the corpus spongiosum and contains the urethra, so they will help in expelling the last drops of urine or semen when they contract the bulbospongiosus muscle. So we have bulbospongiosus and ischiocavernosus. Both of them, they will help in the erection, but they are not responsible for erection, because erection actually is because of the gush of blood that takes place into the cavernous spongy tissue of the penis. This is the glans again. You can see that it is a continuation of the corpus spongiosum, not the cavernosum, but the corpus spongiosum. And this is what I have just mentioned, that erection is a parasympathetic reflex. Sexual stimulation will dilate the arteries supplying the penis, so they will become dilated. Some drugs like Viagra will cause this dilated arteries, and thus will help in erection, because it acts specifically on these arteries that are present in the penis. And as these arteries are dilated, they will gush the blood, and the blood will therefore obstruct the veins, because the veins have thinner walls than arteries, so they can be easily obstructed, and so the blood comes to the penis but will not leave the penis, because the veins are going to be closed because they have thin walls. So the blood enters the penis, compressing the veins so that the blood is trapped in the penis. Ejaculation, on the other hand, is a sympathetic reflex. So erection is parasympathetic, ejaculation is a sympathetic reflex, and here it will result in a contraction of smooth muscles. Some of the smooth muscles are located here at the neck of the bladder. Remember, we mentioned that there is an internal urethral sphincter last time. So this internal urethral sphincter should close during ejaculation. Otherwise, the fluid, the semen, part of the semen at least, can go up into the urinary bladder. And this happens actually not in a normal condition, but happens when, for example, people who have prostatectomy, their prostate is removed, or part of the prostate is removed. During surgery, there might be damage to this internal urethral sphincter, and this will result in what they call it internal ejaculation. Some of the fluid will be ejaculated into the urinary bladder instead of going out. So the first group of muscles that should be contracted are the sphincter urethrae, are the internal urethral sphincter, the smooth muscles that are present at the neck of the bladder. Remember, last time we mentioned about the trigone. There are 3 openings, 2 for the ureters and 1 for the urethra, and this is guarded by an internal urethral sphincter, which is involuntary sphincter. This is actually also, it's a sphincter for not only for urine but also for semen during ejaculation. It should close. And the other muscles are contracting, should they contract rhythmically, and these are the muscle fibers that are present in the wall of the epididymis of the vas, so that to transport the semen from where it is stored in the epididymis into the ejaculatory ducts, and at the same time there will be contraction of the smooth muscle of the seminal vesicle to push the content of fluid here to add it to the semen, okay, and so on. So many muscles are contracting here, including the ischiocavernosus and bulbospongiosus muscle, which will, especially the bulbospongiosus, which will complete the job, as it is mentioned. Complete the job, it means that it will it can expel the last drops of semen or urine, because it's the muscle, the bulbospongiosus, surrounds the bulb of the penis where the urethra is passing. Questions? Yes?
I thought you lived in prostate. You can't have it removed, can you?
The prostate?
Yeah.
Yes, you can have it removed. Yes. Because people who have prostate cancer,
But I thought they just scraped the prostate.
yeah. So if there's cancer, the prostate should be removed. But people who have benign prostatic hyperplasia or hypertrophy, what they do is they do a transurethral resection of the prostate. They pass a resector through the urethra and they remove the core of the prostate. They take it out because when the prostate enlarges, as I mentioned, it will compress the urethra and this will produce problems during urination. So they will take this out from the inside of the prostate. The remaining part of the prostate is there. But if there's tumor, carcinoma of the prostate should be removed. Yeah. If it is resected, depending on the state of the tumor. Yeah. Other questions? Okay.